Myelodysplastic syndrome. How is it with myelodysplastic syndrome? So over here, the cells that mutate, those are very probably hematopoietic stem cells, so up in the tree, or myeloid progenitor cells. Okay. So these are hematopoietic stem cells or myeloid progenitors. This tells you that, yeah, they can transform into ALL, acute lymphoblastic leukemia, but very rarely. It's like 1%. These are new data, the 1%. The older data were like 1/3, but it's less, it's lower. So it's rare, but it's possible. So like 1% or a bit below 1%, the myelodysplastic syndromes, because the mutations are very high, very likely in the stem cell, they can transform into acute lymphoblastic leukemia as well. But 99% of the transformation, if there is a transformation, it goes towards acute myeloid leukemia. Okay, so that's a comment. And let's get to developmental stage. Then this is early myeloid differentiation. So early myeloid differentiation. If we get farther in myelodysplastic syndromes, then the primary physiological process affected. So in this case, it's ineffective hematopoiesis, genomic instability, and epigenetic dysregulation. So ineffective hematopoiesis. This and genomic instability and epigenetic dysregulation. So epigenetic dysregulation. Timing of the oncogenic events. Over here, it's gradual accumulation within the years of the mutations. So then it's, of course, clonal. So accumulation of mutations with age. In contrast to AML, where there are two hits very near each other early. Okay, so this is like a gradual accumulation. Mechanisms of transformation. Well, that's a clonal hematopoiesis with ineffective maturation and cytopenia. So over here, there's the block of maturation. So block of maturation. Okay. Common driver mutations. Well, over here, it's the SF3B1, for example. So SF3B1, ASXL1, or TET2. Let's name just a few. Is there a role of a virus? No. Over here, there is not a role of a virus, so no. Let's put it like that. Common age, typically elderly, so over 60 years. So over here again, over 60 years, elderly. Primary site of disease, it's bone marrow, of course. And typically in the blood, you're going to have cytopenias, as we talked about. So it's bone marrow, okay? Immunophenotyping, so immunophenotype, those are dysplastic cells. There are abnormal antigen expressions, myeloid antigens expressions, so dysplastic. Myeloid, abnormal myeloid antigens. Is it related with somatic hypermutation? Nope. So it's not related. Is it relevant? Is the VDJ relevant over here? Nope. And what about clinical behavior? It's chronic, it's progressive, and it transforms to AML and to ALL. Okay, so remember that. It's a chronic, and transformation to first AML and can also to ALL. And what about transplantation? Of course, allogeneic. So allogeneic hematopoietic stem cell transplantation, especially in the high risk of or progressed myelodysplastic syndromes. Okay, so that was myelodysplastic syndrome. And let's get to another one, next one, which is, those are myeloproliferative neoplasms. I'm going to change the color to make it more fun. So let's do the myeloproliferative neoplasms. And typically, the cell of origin over here, it's a hematopoietic stem cell or early myeloid progenitor. So hematopoietic stem cell or early myeloid progenitor again. And over here, if the mutation is within the hematopoietic stem cell, then again, within the myeloproliferative neoplasms, and we got those four entities over here. We got the chronic myeloid leukemia, we got essential thrombocythemia, we got polycythemia vera, and we got primarily myelofibrosis. And in this case, again, there's a potential to transform into acute lymphoblastic leukemia, but it's very rare. In total, it's like 0.5%. Okay, so if there is a transformation, then rather it's going to transform into acute myeloid leukemia in 99% if it transforms. But now over here with these four entities, we got a big difference, and that is a therapy. Because for chronic myeloid leukemia, we got the tyrosine kinase inhibitors, and they totally changed the prognosis. Because without the tyrosine kinase inhibitors, so untreated chronic myeloid leukemia, it transforms up to 80 to 90%. And in case it transforms within the years or months without the treatment, 20 to 30% have a lymphoblastic transformation, so into acute lymphoblastic leukemia. Okay, the rest is into acute myeloid leukemia, but it's so high. So, but with treatment with the tyrosine kinase emitters, it lowers down to 1 to 5%. And with the other ones, the most common, which undergoes a transformation, is the primary myelofibrosis, that like in 10 to 20% within 4 to 7 years. Okay, so this can transform. Then it's polycythemia vera with like 5 to 10% that it transforms, again, usually to AML, of course, within 10 to 15 years. And the essential thrombocythemia or essential thrombocytosis, that's only in 2 to 5%, and it takes more than 15 years. But it's a low risk, but there is some risk with the transformation, okay? And very, very low number. Typically, it transforms into AML. Okay, but remember, in chronic myeloid leukemia, untreated, and 80 to 90% transform within months to years, and 30% of them is ALL-like, so acute lymphoblastic leukemia. Okay, so let's get to the new point. What is the developmental stage? It's naturally early to mid myeloid differentiation, so early to mid. Okay, what is the primary physiological process affected? So it's the clonal expansion of myeloid lineage, so the XAT pathway, etc. So BCR-ABL1 typically in chronic myeloid leukemia, so clonal expansion of myeloid lineage. Okay, then the timing of oncogenic events. Well, so it's acquired postnatally, so associated with chronic inflammation or cytokine signaling. That's crucial. Okay, so again, the timing is postnatally, when you're older, of course, and it's associated with chronic inflammation. Chronic inflammation could be, and cytokine signaling. Mechanisms of transformation, that's the hyperproliferation. So they mature, but there's too many of them, okay? Typically, it's a hyperproliferation of the terminally differentiated myeloid cells, red blood cells, platelets, okay? So they differentiate and mature, but you have lots of red blood cells, platelets, grounds, and they're functioning pretty well, okay? But depends. Common driving mutations, that's crucial. So Janus kinase, YAC2 mutation, very crucial. And BCR-ABL, of course. BCR-ABL1. Yep. Yeah, we got that too as well, etc. Is there a role of viral infection? Rather not. And common age group, again, it's adults and elderly. Typical mean is about 60 years over here. And primary site of disease, that's bone marrow with peripheral cytosis. Okay, so bone marrow again, of course. And immunophenotype, there are lineage-specific markers like CD41 positive and CD71 positive. There are, of course, many more, but you don't have to know this. And it's MPO positive. Is there somatic hypermutation? Nope. it's not related, no, not involved. It's not VDJ is not relevant as well. Clinical behavior, it's chronic. It's transformation to AML typically later. So chronic, again, transforms into AML and can transform into ALL as well. Okay, and what is the treatment? Well, allogeneic hematopoietic stem cell transplantation. So allogeneic. Okay. Next one is ALL. So thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.